Welcome everybody to the 2020 Utah Homeless Summit. It looks quite a bit different this year than our usual gathering. A quick funny story, we're grateful to be able to deliver this Homeless Summit via Zoom. I'm broadcasting today from my office, which is pretty sparse here these days. We don't have a lot of people in the office. One of the reasons I'm doing it from my office today, a quick funny Zoom story. I chair another board, and I was hosting a board meeting from my home, which is in my front room, right by my front door, right in the middle of my board meeting. It was getting close to lunchtime. I noticed in the background my son going to the door to get his DoorDash, barely had woken up, no shirt on. We wanted to make sure we avoid all those complications. We've practiced a lot of delivery of this via the Zoom platform. We want to make sure it is exactly what you're hoping it will be. Although we have great speakers and learning sessions for each of you, one of the things we will all miss is being able to see each other face to face and do some in-person networking. While the dynamics have changed tremendously in how we meet and how services are provided in our communities, we see how much our communities rise to the occasion. We honor those who are serving under tough circumstances. We often hear about stretched capacity and long, hard hours of those on the front lines. We hear about the critical health issues of those being served and how important it is for them to get the right care at the right time. We hear about increased mortality rates for those who may not be able to get the care they need. Now, most of that context we hear right now is about our frontline healthcare workers dealing with COVID-19. With far less attention, I honor each of you working on the front lines of homelessness, facing these challenges for many years. We know you are challenged not with just capacity at your current facilities, but with the treatment options like housing, mental health, and substance abuse treatment for your clients. We know how important it is to provide these interventions when they are needed, not when they are just available. We know those living on the streets have significant life expectancy reductions as compared to those receiving services, and for those not experiencing homelessness at all. So for those of you on the front lines of serving our homeless friends, we thank you today, and hopefully every day you feel our appreciation in helping those who are the most vulnerable. You have been dealt unique challenges over the last 7 months as we respond to COVID-19 as a community. You have adapted and provided outstanding care and compassion in difficult circumstances. Joining me today to thank you is a special video message from our Governor, Gary Herbert, and the Chair of the State Homeless Coordinating Committee, Lieutenant Governor Spencer Cox.
Hello, I'm Governor Gary Herbert. For many in our state, COVID-19 has disrupted their lives and redefined their daily routine. For homeless friends, they have never been more in need of the devoted care that each of you provide for them on a daily basis. We wanted to extend our gratitude to you and thank you for continuously serving those in need, particularly the homeless. It's clear to us that no matter the circumstances, you will look after your neighbors. We appreciate your efforts to help us slow the transmission of COVID-19, and we admire your loyalty, your compassion, and your perseverance. So thank you so very much.
Thank you for championing the needs of our underserved even during a pandemic. As a state and as local communities, I know we will continue to provide assistance to our neighbors when they are their most vulnerable and help them return to self-sufficiency. Even though we have faced many challenges and hiccups along the way in addressing homelessness, we will continue to work together to collectively respond. You are on the front lines of some of the most challenging and important work our state has ever faced. Keep up the good fight by preserving public health and inspiring hope in your communities.
We appreciate our governor and lieutenant governor. We know that they're very interested and involved in helping to respond to the needs of homeless populations, not just when COVID-19 has been out there and in front of us, but all along they've been tremendous supporters. I can definitely speak to that. We wanted to highlight a little bit of the progress that is happening right now in our homeless system. If you'll recall, last year we had unveiled the strategic plan on homelessness, and it's being implemented. So many of the steps that we outlined there and were adopted last September have been implemented this year. And we're all working together to achieve this common goal to make homelessness rare, brief, and non-recurring. The Utah Homeless Network was formed with the local homeless coordinating committee leadership, and we'll talk a little bit about this. Utah Homeless Network has been very valuable. They meet regularly. During COVID-19, they've been meeting weekly to share best practices, understand data and trends, build social network on professional support, provide funding recommendations to the State Homeless Coordinating Committee, and advocating for effective homelessness response. I know we've got some workshops that you can get to know a little bit about what's happening in that network and your local homeless coordinating committees. We appreciate all the leaders that are involved in that and pushing that work forward. That's so important. They have been meeting weekly, like I said, on the COVID-19 response. And they've been doing this gap analysis for the State Homeless Coordinating Committee to identify the resources in their community, what services are available, what the gaps are, so that we, as a state, can help invest in the local needs in the community. So we really appreciate that. We talked a little bit last year about the new homeless resource centers in Salt Lake County that were completed. Some had been populated, some were about to be populated. The 3 are up and running now, running up at capacity. There's been a little bit of modifications on capacity from COVID-19. Just a tremendous job for those organizations running those centers. Really appreciate Volunteers of America, Shelter the Homeless, Catholic Community Services for a while, and the Road Home for helping to operate those centers. They've been so instrumental in helping to deal with the challenges that we're facing. We've recently published our 2020 annual homeless report. We'd encourage you to go read it, get familiar with the data. A lot is talked about of our system performance measures, which I'll get into in just a second. And I'd encourage you to make that your Bible for the year and study it, understand what it says, and how we can improve upon those things. Let's talk a little bit about the data, how we're making progress, what's happening in our system as we look at our system performance measures. These are regular things that HUD looks at, and we have adopted in our strategic plan to look at to see if we're making progress in our system. So the first one we're going to look at is making homelessness rare, and this is measured by the percentage of system users that are experiencing homelessness for the first time. You'll see it's been a pretty steady measure. I will say this measure has its ups and downs to it. It's good to have less people experiencing homelessness, but when you measure it as a percent of your overall system, on the other side, you're looking at people who are returning to homelessness. So although we want this number to be low, we also don't want the other side of it to be high. So there's a little bit of a balance there, but we want to make sure that we're trying to get to folks before they become homeless and help provide interventions so they don't have to experience homelessness. So that's one of the things we're looking at here. We're pretty steady over the last 3 years. Let's look at the next piece, which is making homelessness brief. This is the average length and median length of time homeless. And you'll see this has gone down a little bit from 2 years ago. And another thing about these pieces of data, this ended September 30th of 2019. So this is a little bit older data. We do update this. They get talked about beforehand, but this is what's published in our homeless report as a year-long look. And what we've seen is that we've gone down a little bit since federal fiscal year 17, which is good. We want to shorten those lengths of stay, help get people connected to housing, and exit our homeless system on a pathway to success. So good work on getting that average length of time done over the last couple years. We need to continue to make improvements on this. The next piece of information is making homelessness non-recurring. So we have a couple of graphics here. On the left-hand side of your screen, you'll look at the total percentage of total returns to homelessness. This is the other side of the equation that I was talking about. And we definitely want to see this number drop. And it has over the last 2 years. And we're hoping that with the systems of care that we've set up, and a transition to these new resource centers that will continue to make strides here in helping those who have exited the system not have to return. So they're set up for success when they exit. And we really appreciate your work here and looking at reducing recidivism and homelessness. On the other side, on the right-hand side of the screen, you'll see the percentage of successful housing outcomes. This is important. That top one is a really important number, 93% so far for federal fiscal year 19. These are people who have been placed in a permanent housing project within our homeless management information system, and those who have retained that or have successfully exited to another permanent housing destination, 93%. So only 7% of the clients that were in those situations returned into another area of our homeless system. So that's a great number right there. We always want to be pushing that number up. The middle bar there is the percent of successful exits from emergency shelter, safe haven, transitional housing, and permanent housing, rapid rehousing who exited. So that is also an important number. If we're taking people from emergency shelter, we want to get them into a successful exit into permanent housing. That's remained pretty steady. We want to see that continue to grow. So that's another thing we'll be keeping our eye out on. That bottom one is people exiting from the streets to a successful exit. You know, those of you who work with street populations know you're not going to get 100% right from the streets to a permanent exit. Oftentimes there's several steps along the way, and we want to continue to push that up. Really appreciate our street outreach folks and those who are responding to unsheltered populations and helping people get connected to services. So that's kind of the snapshot on what's happening with the data. Let's go to the next slide. In conclusion, there's 70 service organizations engaged with the local homeless coordinating committees and our state homelessness programs office. We have more than 660 individual service provider staff that enter data into the homeless management information system. And last year, we had, in last fiscal year, we had 23,000 clients enrolled in projects in the homeless management information system. That can be anything from emergency shelter to just receiving some, clothing or other types of items that are recorded as a homeless service there. So we know that we're serving a lot of folks. You guys are on the front lines doing this each day, and we really appreciate everything that you're doing there. A couple recognitions for those who have helped out to put our Homeless Summit on. We really appreciate this. First, from our Homelessness Programs Office, we want to thank each of these individuals. I know you're all applauding, doing your virtual applause for those who have really helped out in putting this together. So thank you for our Homelessness Programs Office. Also, our staff from the rest of the Department of Workforce Services that have helped to line up the videos, put everything together, our programs, make sure this goes as smoothly as possible. And lastly, we want to thank those of you in the community that have been a big part of planning, deciding which workshops to put on, participating in those workshops, or lining up the folks that would be presenting. We really appreciate your help and all your involvement in that effort. So thanks to all of you. With that, we're excited today to introduce our keynote speaker. I just met her in person just a few minutes ago, but I know we've had several discussions with her prior to her presentation today. It's my pleasure to introduce Margot Kuschel, MD. She's a professor of medicine at the University of California, San Francisco, and director of the UCSF Center for Vulnerable Populations and the UCSF Benioff Homelessness and Housing Initiative. She's a practicing general internist at Zuckerberg San Francisco General Hospital. Margot's research focuses on the causes and consequences of homelessness and housing instability with the goal of preventing and ending homelessness and ameliorating the effects of homelessness on health. She speaks at a local, state, and national level about issues of homelessness and provides testimony to legislative bodies. She received her AB from Harvard College, her MD from Yale, and completed residency, chief residency, and fellowship in internal medicine at UCSF. We're very excited to have her. We're going to give you applause virtually, Margot, to welcome you. And I know we're excited to hear what you have to say for the next little bit. So with that, I'll turn the time over to you, Margot.
Thank you so much, Jonathan, and thank you everyone for joining us today. I'm Margot Cushel. It's really nice to meet you. And I always encourage people, if you're interested and want to follow things on homelessness, to feel free to follow me on Twitter at @mcushel, where I often tweet about all things homelessness and housing. Today, I'm going to talk about homelessness, causes, consequences, and solutions. I'm going to start by just setting a framework of why people are homeless. So why are people homeless? I like to think of this wonderful framework that was written by Marty Burt in the late 1990s that describes homelessness as an interaction between structural factors. Things like affordable housing, jobs for low-wage workers, income inequality, and individual vulnerabilities, things like mental health disabilities, substance use disorders, and adverse childhood experiences, and the presence or absence of a safety net, things like income support, safety net healthcare, and subsidized housing. The less favorable the structural factors and the availability of the safety net is, the fewer individual vulnerabilities that one needs to become homeless. We know in the United States, since the early 1980s, we have seen a stagnation of wages of low-wage workers, where the top 1% of workers' income has grown 138% since 1979, but wages at the bottom, 90%, grew only 15%, not nearly keeping up with increases in the cost of living and in housing. This intersects with a dramatic shortage of the availability of housing for extremely low income renters or households who make less than 30% of the area median income, generally those low wage earning households. This is both because housing costs have risen dramatically, because there has been a disinvestment in subsidized housing by the federal government, and because of that wage stagnation. No state in the country has an adequate supply of affordable rental housing for the lowest income renters. Nationally, there are approximately 36 units of housing that are affordable and available for every 100 of those extremely low income renters in their area. In Utah, there are 31 units of housing affordable and available for every 100 extremely low income households. In California, my home state, we are the second worst in the country, clocking in at 23 per 100. And Nevada, the state in between our two states, has the lowest in the country at 18 units available for every 100 extremely low income households. As most of you know, this problem is compounded by the fact that rental assistance is not an entitlement, and few who need it actually receive it. There are many problems with rental assistance that go beyond this. For instance, the qualifying income is very low, and many people who could probably benefit don't qualify. On the other end, there are problems too. Some who get it aren't able to use it. But this statistic is merely that amongst those who meet all criteria for getting it, only fewer than 1 in 4 households overall who qualify receive it, and about 1 in 3 elderly households receive any form of rental assistance. We know that homelessness is more common in areas with more expensive housing costs. Areas like my hometown of San Francisco, California, have extremely high rates of homelessness, as well as high housing costs. Other areas, New York, Los Angeles, Seattle, have extremely high homelessness rates. Areas with lower housing costs tend to have lower rates of homelessness, although all homelessness is unacceptable. We know that together, rising housing costs and low wages create housing insecurity and leads to homelessness. The COVID-19 pandemic is worsening this crisis. We know that the economic fallout from COVID-19 continues to hit those lower income Americans the hardest. Half of adults who say they lost a job due to COVID are still unemployed. And we're seeing rising rates of individuals saying that they are unable to pay their rent. This burden is falling disproportionately on the Black, Latinx, and Indigenous population. Which brings me to my next point about structural causes of homelessness. It's really impossible to have a discussion about homelessness without noting that homelessness is a racial justice issue and is deeply influenced by structural racism in our society. I want to remind everyone here that in our country, housing has been the primary means of wealth building for our families across generations. But because of perfectly legal until relatively recently, but also racist policies, there was widespread discrimination in home ownership, starting with the home ownership boom following World War II. Neighborhoods were segregated by policies such as racial covenants, and banks followed redlining, which meant that they restricted access to mortgages in segregated neighborhoods, meaning that Black and brown households were only allowed to purchase houses in certain neighborhoods and were either entirely unable to get mortgages to do so or had to get mortgages at very high rates. This has contributed to a huge deficit in home ownership in the Black and brown community, and to decrease wealth in those communities directly, and decrease costs of housing or decreased value of housing that is owned. Even though it then became illegal, we know that Black and brown communities have been affected by unfair housing practices. They were most impacted by the predatory lending crisis, which led to the housing bust of 2008, and were much more likely to lose wealth through foreclosure. And they are subject to ongoing discrimination in the rental housing market, even though it is no longer legal to do so, such that there's well-documented evidence that you are a Black family and you present to a landlord with a very similar housing resume to a white family, the Black household is much less likely to be able to get the apartment and winds up paying a lot more for the same quality housing. You add into that discrimination in the criminal justice system, employment system, and educational discrimination, knowing of course that our public education system is fully linked to where you live. Perhaps it's not a surprise that Black Americans are at a 3- to 4-fold increased risk of homelessness across this country. So who is homeless? In our last national point-in-time count collected at the beginning of 2019, there were 568,000 homeless people who experienced homelessness in America at one point in time. It's estimated that 2 to 3 times that number experienced homelessness over the course of a year. 70% of those were individuals, meaning that they were homeless without minor children, and 30% were people living in families. 6% of the overall population, distributed between families and individuals, were unaccompanied youth 18 to 24 living with or without their own minor children. Overall, 63% of those who experienced homelessness were sheltered, although the rates vary widely across region. In New York, that's about 4%, whereas in California, that's about 72% who are unsheltered. 17% of all those who are homeless were designated as chronically homeless or homeless for a year or more with a disabling condition or 4 or more episodes in the prior 3 years. And overall, 60% of all people who are homeless were men. It's actually a higher proportion in the single or individual homeless category. Black, Native Americans, and Latinx individuals and families are overrepresented in the homeless population. As you can see nationally, 13% of all Americans identify as Black or African American, and 40% of those who are homeless are. Latinx, 18% versus 22% who are homeless, and Native American and Alaska Native, 0.9% versus 3% in the homeless population. In Utah, there were 2,798 people homeless at that 2019 point in time count, with 63% individuals, 31% in families, 6% were unaccompanied youth. These numbers are remarkably similar to national numbers. In Utah, 88% of the population were sheltered, a higher rate than is sheltered across the country. 59% of Utahns who were homeless were experiencing homelessness for the first time, and 18% were experiencing chronic homelessness in 2019. In Salt Lake City, Latinx, Black, and Native Americans are overrepresented. You can see that Latinx populations were 23.9% were homeless compared to, or Latinx compared to 18.8% of the general population. For Black and African Americans, 12.6% of those experiencing homelessness in Utah, in Salt Lake, were Black or African American, compared to 2.2% of the general population. And American Indian and Alaska Natives were also highly overrepresented, with 5.5% of your homeless population versus 1.4% of Native Americans or Alaska Natives in the general Salt Lake community. The homeless population is higher at both ends of the age spectrum, older and younger. The homeless population is currently aging. We found that in San Francisco in the early 1990s, 11% of those experiencing homelessness were 50 and older. And by the time we stopped that study in 2003, 37% were. Now, approximately 50% of individual homeless adults in San Francisco and actually across the country are 50 and older. My colleague Dennis Culhane and his colleagues shown that this is due to a generational effect. There is people born in the second half of the baby boom, so about 1955 to 1965, have been at an elevated risk of homelessness their whole lives. You can see a big spike in the proportion of people who are homeless in the 1990 who were age 31 to 33, or people born in that age cohort. As that age cohort raises, so does the median age of people experiencing homelessness. In 2000, there was a big spike of people in their early 40s, and in 2010, in their late 40s, early 50s. When you think about it, people born in the second half of the baby boom have not had a lot of breaks. This was a generation who was the second half of a large population shift, where the earlier half actually took most of the jobs. They were a population that entered the job market during a recession, and we know that people who do that never regain the lost income throughout their career. They were the first generation to be caught up in the era of mass incarceration, and the first generation who hit adulthood in an era starting in the 1980s with a massive retrenchment in funding for affordable housing. Thus, perhaps it is no surprise that this generation has struggled with homelessness throughout their lives. And in fact, this is anticipated to continue. The fastest growing group of individuals experiencing homelessness are those who are 65 and older, whose numbers are expected to triple between 2017 and 2030. Again, this is data from my colleague Dennis Culhane and his colleagues, showing in Los Angeles, Boston, and New York City the anticipation of this phenomenon. We did a study, we have an ongoing study called the Hope Home Study, which chronicles adults 50 and older who are homeless in Oakland, California. We started enrolling folks in 2013, 2014, have been following them ever since. One of our most important findings was this: among adults who are homeless and 50 and older, 44% had never been homeless before the age of 50, not even for a day. As you can see, the age of first homelessness varied throughout the population, but a very large group of individuals were never homeless before they were 50. And in fact, we have found that those whose first homelessness was late in life had very different life trajectories than those who were first homeless earlier and remained homeless throughout their adulthood. At the other end of the age spectrum, we also see a spike in homelessness. And in fact, the single most common age to experience sheltered homelessness in this country is infancy. If you had to pick one year that was the most common year for people in American shelters, it would be under 1. Pregnancy and the postnatal period is a very high risk time for homelessness, leading many, many infants in our country to experience homelessness. And 19% of all Americans experiencing homelessness are children living in homeless families. How about homelessness and health? Because I am a physician after all. The easiest way to say this is that homelessness is devastating for health. One main way that we measure health is simply asking people to report their self-reported health status, ranging from poor or fair to good, very good, or excellence. It has been shown that this simple measure is highly effective at anticipating who might wind up hospitalized or dying in the near future. In the general population, about 10% of people report their health as fair or poor. In the poverty population, about 24% do, and in the general population, and in the homeless population, more than 36% report their health as fair or poor. Among older homeless adults, 56% of the population reports their health as fair or poor. We see an elevated age-adjusted mortality rates of homeless adults, although the causes vary by age. Among adults who are homeless and age 25 to 44, the elevated death rate is primarily caused by drug overdoses, heart disease, substance use disorders, and HIV. This population experiences a mortality rate 9 to 10 times higher than the general population. Amongst homeless adults over age 45, we see that the main causes of death mirror the causes of death in the general population, mainly cancer and heart disease. This simply happens more commonly and earlier, such that mortality rates are 4 to 5 times higher than the general population. Homeless people have higher rates of chronic diseases, no matter which kind you talk about. In this graph, we look at some common health diseases, and we can see things like asthma, chronic obstructive pulmonary disease or emphysema, heart problems, and epilepsy are significantly more common in homeless versus non-homeless populations. You might notice that diabetes appears to be not much more common, but here's the thing. Most people with type 2 diabetes, which is by far the most common form of diabetes, are not aware that they have that. And the lack of the increase in rates of diabetes may in fact simply be due to a lack of noticing or acknowledging that people have diabetes because of difficulty accessing healthcare. In those 50 and older, we see a very high proportion with functional impairments. For instance, in our study, we found that almost 40% had a limitation in an activity of daily living, with over half of those having 2 or more. These limitations in things like bathing, dressing, toileting, transferring, and eating place you at high risk of requiring nursing home placement. We found that half had a disability in instrumental activities of daily living, things like being able to fill out a form or being able to take public transportation, with about half of those having 2 or more impairments. We found very high prevalence of cognitive impairments. Over a quarter of individuals 50 and older had a moderate or severe impairment in global cognitive function, things like working memory, ability to follow tasks, and judgment were highly impaired in this population. We found that 35% had a moderate or severe impairment in executive function. Executive function is the ability to follow sequenced tasks. Things like you need to go to this office Monday or Wednesday, Friday morning and pick up forms and bring them to that office. That is exactly what someone with executive function is unable to do. And yet that is exactly the demand we place on elder homeless adults. In those 15 and older, we frankly saw a high prevalence of all geriatric conditions. Things like mobility impairment, having 1 or more falls, visual impairment, hearing impairment, and urinary incontinence, where almost 48% of our study participants reported urinary incontinence. Imagine trying to find housing or a job if you had no access to laundry facility or clean clothes and you had urinary incontinence. All of these data are from a study population where the median age was 57. But despite this, the rates of things like cognitive and functional impairment and other geriatric conditions were higher than that we see in the general population in their 70s and 80s. Mental health problems are also common throughout those experiencing homelessness. The most common mental health problem is not what you might think. It's actually depression, with a quarter to a third experience moderate to major depression, and 16% have diagnosable substance use disorders. A higher proportion use illicit substances, but in terms of substance use disorders, it's estimated that about 1 in 6 to 1 in 5 have a full-blown substance use disorder. Homeless children also have poor health, with over a third reporting asthma, about a third reporting childhood obesity, 30% have either developmental or psychiatric diagnosis, and 19% of those younger than 3 had iron deficiency anemia. Homeless individuals report chaotic use of the healthcare system, with high rates of emergency department use and hospitalization. In fact, 40% of all of those experiencing homelessness report an ED visit in the past year, compared to 11% in the general population. In our studies of those over 50, approximately 50% reported an emergency department visit that we were able to verify occurring just in the past 6 months. In both the younger and older populations, there's a very small group that accounts for most of the emergency department visits. In fact, it is fewer than 7% of the homeless population who account for over half of all ED visits. We call these individuals high utilizers, and they tend to have very high rates of substance use disorders, mental health problems, and violence and victimization. We see overall low rates of non-emergency department ambulatory care. Things like scheduled visits for chronic diseases are very rare and contribute to the high rates of ED utilization. We know that people who experience homelessness are much more likely to have hospital stays. This is both because they have more underlying conditions that lead to hospitalization. They're less likely to have conditions taken care of early, and thus they wind up hospitalized. And also, frankly, because we physicians lower our admission thresholds for people who are homeless, because it is simply so much harder to care for people who are experiencing homelessness when they don't have a place where we could get them care or reliably get them medicines. We know that once admitted to the hospital for the same reason, homeless individuals have longer hospital stays, and they're much more difficult to discharge. And studies in Canada, where there's universal health insurance, have shown that homeless individuals were 3 times more likely to be readmitted within 30 days for the same set of illnesses than those who are not homeless, but those who are poor but not homeless, with a readmission rate of 22.2% versus 7% for control group of poor individuals who are non-homeless with the same admission diagnoses. This talk can feel overbearing and hopeless, and so I want to turn my attention now to what we can do, because the good news is we actually do know how to prevent and end homelessness if we rely on evidence-based strategies. The first strategy and the first thing to attend to has to be increasing our supply of extremely low-income housing, or ELI, extremely low-income housing, housing affordable to those who make less than 30% of the area median income. Our messaging has to be that to solve homelessness, we need to produce, preserve, and protect ELI housing that is targeted toward those who are extremely low income. There's great sources of information about this in the National Low Income Housing Coalition. These numbers below reflect the National Low Income Housing Coalition in Utah, where, for instance, 72% of Utah households who are extremely low-income renters face severe housing cost burdens, meaning that they are currently spending more than half of their income on rent. It is estimated that Utah is short almost 41,000 rental units affordable to this population. That's what it would take to solve Utah's ELI housing problem. We know, and you've probably heard, that eviction prevention plays an important role. Some strategies for eviction prevention include creating just cause housing laws so that it strengthens tenants' rights and make it more difficult for them to be evicted. It has been shown that giving renters access to attorneys or legal representation in housing court can stave off evictions and keep people housed. Another strategy is simply to offer one-time payments to bring people up in rental arrears if they fell behind in their rent because of a sickness, a brief job interruption, and the like. This has gotten a lot of press during the COVID era, where so many households face eviction. Currently, there are local, state, and federal eviction moratoria, most recently enforced by the Centers for Disease Control in recognition of how disastrous evictions would be for the spread of COVID. The problem with these eviction moratoria is that they do nothing to bring people up from being behind in rent. What they do is forestall eviction until the moratorias lift, at which point their rent will be due. We very much fear what will happen if this happens before there is federal rental relief to help people pay off these bills. This would not be good for either tenants who would face eviction or frankly landlords, many of whom are mom and pop operations whose own housing or whose own rental property could be placed in foreclosure if they can't get any rental relief. There have been studies that have been shown the success of emergency housing assistance. My favorite was a study in Chicago where Catholic Charities were offering one-time payments of up to $1,500 for qualifying leaseholder families who were at risk of eviction because they were behind in their rent. That program had a fixed pool of money. On some days, people would call and they would be able to get, if they qualified, this one-time payment. Other days, individuals would call, the program would be out of money, and even though they qualified, they weren't able to get it. Some economists realized that this offered a great opportunity for what we call a natural experiment, and they compared those who received the money to those who called on days but happened to call on a day where there was no money. They found that families who called when housing assistance was available were 76% less likely to enter shelter at 6 months. This was great news. However, when they looked more closely, the absolute decrease in the number of people going to shelter was only 1.6%. This is because very few people in either group wound up homeless. In fact, 99.6% of those who received housing assistance remained housed, whereas 98% of those who didn't receive housing assistance remained housed, meaning most people who are facing eviction did not immediately become homeless. What their study showed that even preventing only 1.6% of shelter stays was very cost reasonable. For an average cost per caller of $720, they averted a homeless spell for an average cost of $10,300. They reran the numbers and said what would have happened if they restricted the payments only to the very lowest income callers. If they had done so, they would have prevented about the same number of episodes of homelessness, because really only these individuals wound up homeless, and they would have been able to reduce the cost per episode averted to $6,800. This reinforces a principle that you really want to target your payments if what you're trying to do is prevent homelessness. And this program soon after did change their qualifications. But it turns out to prevent homelessness, your best option is not to focus on leaseholders, because most of those don't wind up homeless. It's very important to prevent evictions, because evictions themselves are extraordinarily damaging. But if what we're trying to do is prevent homelessness, we actually need to focus on even more at-risk people. It's important that prevention efforts need to be both efficient and effective, and I'll explain what that means in a moment. This comes from Beth Shin, and in the spirit of full disclosure, I'm actually related to her, and Ajay Kurduri's amazing new book, In the Midst of Plenty, Homelessness and What to Do About It. Efficient prevention efforts means that they are appropriately targeted to people who are most likely to become homeless. Effective ones mean that they provide the right resources to prevent homelessness. What they recommend is that we focus prevention interventions on the highest risk populations. People like youth exiting the child welfare system, those leaving psychiatric hospitals, and imprisoned people leaving incarceration are at such extraordinarily high risk of homelessness that focusing interventions on these populations would be highly efficient. For others, they have shown that using statistical modelings with some clinical input or some ability for frontline workers to override the models performs much better than relying on clinical judgment alone. This is because frontline workers are more likely to give prevention resources to lower risk individuals because frankly, they seem like it's more likely that the small amount of resources would make a difference. Even though this is counterintuitive, this doesn't turn out to be true. They found, for instance, that among single homeless adults, the single most important predictor of whether you were going to become homeless was whether you've been homeless in the past. At focusing prevention resources at people with a past episode of homelessness was a highly effective and efficient way to do so. Those without leases, those who had already lost their lease and were doubling up with family or friends, was also another high-risk group. This graph explains why it's so important to target resources. On the x-axis, where you see the numbers 1 through 10, those represent the number of risk factors and the severity of risk of homelessness using these statistical models. On the left side of that, between numbers 1 to 5, you can see that not many people became homeless. Became homeless is the amount of people represented by, for instance, these red bars. The dotted lines are people who received the intervention. The solid line are people who didn't receive the intervention. You can see on the left side of this graph between 1 to 5, not many people failed. Not many people became homeless. That's good news. Except if you look at the difference between the dotted and straight lines, you'll see that not many people became homeless whether they received the intervention or whether they didn't receive the intervention. As you start focusing your prevention resources on higher risk individuals, you're going to see a lot more failures, a lot more people who receive the intervention, and these interventions included things like rental assistance, legal help, benefits counseling, one-time payments, and others. A lot more people who actually received the intervention actually wound up homeless. On the other hand, you're also going to see that the program prevented more episodes of homelessness, represented by the difference between those who had received the intervention and similar people who didn't, or by the blue bars. This leads me to say that if you are running a homeless prevention program and you do not have any failures or people who wind up homelessness, you are probably not delivering services to the people at high enough risk to benefit. Or as I like to say, if you gave me and Mark Benioff each $1,000, neither of us would become homeless in the next 6 months. If you judged your program on whether we became homeless, you would think you had a highly successful program, but you were probably just not targeting it to the right people. Let's talk about what we can do once people become homeless. It turns out there's a very clear evidence base on what we need to do. All reliable evidence supports housing first policies. Housing first policies encourage us to start with the housing. They encourage us to not require sobriety or an engagement in services, whether they be mental health, substance use, or any others, prior to getting housed as a precondition for housing. When you start with the housing, you do not rely on transitional housing that you need to succeed in before going to permanent housing, or you do not rely on a stepwise increase in shelter and care. You do not have to show your worthiness by going through shelters and succeeding in them. They do not require shelter stays prior to housing, although acknowledge that shelters can be an important emergency response. Programs that use housing first policies have been shown time and time again to have faster and more durable exits from homelessness, with shorter time to leave homelessness and more time in housing. Housing first policies are better whether you're looking at interventions that require or don't require robust services. For those with severe behavioral problems in chronic homelessness, the evidence all points to the success of permanent supportive housing. Permanent supportive housing is simply subsidized housing that is linked to voluntary supportive services given on a housing first model, where you start with the housing. These programs have been shown to be highly effective at keeping people housed, although I will acknowledge that we need to make minor adjustments to meet the needs of our aging population. PSH has been shown to be highly effective even for very high-risk populations. We recently completed and published a study, a randomized controlled trial, which is the gold standard of studies, for the highest risk chronically homeless population in Santa Clara County, California. This project, called Project Welcome Home, intentionally selected the most highest risk individuals with chronic homelessness. We developed a model to find the 400 highest risk chronically homeless individuals living in the county, and we flagged them to include them in the trial whenever they entered services. What this shows, just to give you a sense of how impaired this population was, that among the study participants in the prior 2 years, they had an average of 5 inpatient admissions to the hospital, medical or psychiatric, 19 emergency department visits, and 4 jail stays on average. This was a highly at-risk population. We only had about 120 units of permanent supportive housing, so we flipped a coin whether people who got in or didn't. Anyone who didn't get in was still available to get whatever else was open. Our intervention group was offered immediate entry into a permanent supportive housing program that was staffed in intensive case management program, which meant that they had a team of social workers and others on a 1:15 ratio. These teams were led by a master's trained behavioral health worker, a social worker, or an MFT counselor who was working in a team structure with a bachelor's trained caseworker and a peer counselor. Together, that team of 3 would take care of approximately 45 individuals. The program offered temporary housing if no permanent unit was available at engagement. So as soon as you were enrolled in the program, you were offered a place to stay if there wasn't a permanent unit available that day. Those temporary housing units were also available. If your first housing didn't work out and you needed to be rehoused, you could go to a temporary unit before you were rehoused. Most of the housing was scattered site, meaning that the program simply rented apartments throughout the county and then brought the team of workers of the support team to individuals. The services were entirely voluntary. They included mental health and substance use services, medication support, connection to primary care, educational and vocational support, community living skills, money management, and leisure and spiritual opportunities. The usual care group retained all eligibility for housing or other services. The time of our study corresponded with a rapid expansion of permanent supportive housing in the community we were working in, such that many in the control group received similar services. What we found was, despite this population being amongst the highest risk population, the people who had severe substance use and mental health disorders, 86% of all of those who were approached in an intervention group were housed. On average, it took 75 days after enrollment to get them housed. This meant was that it doesn't always work on day 1. If you approach someone in the emergency department or who's exiting jail and offer them housing, if they're this impaired, it might not take the first day. On average, it took 2.5 months. 70% of those who were housed required rehousing, with an average number of leaves of slightly over 2. But of those 86% who were housed, 93% of the time over the next 4 years, they remained housed, meaning that once people got housed, they stayed housed despite their being extraordinarily high risk. Those in the intervention group spent on average in the following year 6.6 days in shelter compared to 16.8% in the usual care group. However, I want to emphasize that this is in a community where most people who are homeless are unsheltered, so counting shelter stays is not a great measure. We found a dramatic increase in the use of outpatient mental health services amongst those in voluntary permanent supportive housing, and decreases in psychiatric emergency department visits. Those in the intervention group had an average of 37.3 outpatient mental health visits compared to 19.7 in the usual care group. And those in the intervention group had an average of 1.3 psychiatric emergency departments a year compared to 1.9 in the usual care group. We found a very high mortality rate in both groups, suggesting that if you wait until people are this impaired, permanent supportive housing can't necessarily save their lives, although it will say, at least when they died in housing. We did not see huge decreases in other healthcare utilization in jail use. This is a different finding than many studies of permanent supportive housing that have not had a control group. What we know is that in very high risk groups, there's something called regression to the mean, where use overall decreases, and we found that in both groups. But I will mention the fact that 36% in our control group received similar permanent supportive housing, and this would have decreased our ability to find a minor difference in use of services. We were not the only randomized controlled trial to find this. A similar study that came out a year or two earlier, but started about the same time that ours did, in Canada, called the Shea-Swa study, looked at permanent supportive housing in 5 cities in Canada for people with severe mental illness. In their population, 34% experienced psychosis and 2/3 had a substance use problem. And at a 2-year follow-up, they found that those in the intervention group, 73% of their time in the stable housing compared to 32% in their usual care group. And only 8% of those enrolled in the intervention described a negative life course event compared to 36% in the usual care group. You may ask, does permanent supportive housing save money in healthcare costs? In the Canadian study, they found that those who went in with moderate needs, they had a return of $3.40 for every $10 that was spent on services and housing. On those with very high needs, they basically were able to offset the cost of housing and services by decreasing health services utilization. But what I want to say is that the goal of permanent supportive housing is to house people with complex behavioral needs. Housing first is clearly the gold standard, and it is vastly better housing outcomes and alternatives for highly impaired populations. It may not save money, but it does end chronic homelessness. For people with less behavioral complexity, housing first without services is the best option. In this famous randomized controlled trial of families experiencing homelessness called the Family Option Studies, they randomly selected homeless families for 4 possibilities: a subsidy only, where the families were given a housing choice voucher with no other services; rapid rehousing, where families get short-term, time-limited subsidy plus services meant to bring up their income and help them locate housing; transitional housing, where families were placed in housing for 2 years, during which point they were supposed to identify permanent housing; and usual care. What they found was that the group randomized to receive vouchers had less family separation, less substance use, and less food insecurity at follow-up, and most importantly, were much less likely to be homeless. Only 16% of those who were given a voucher with no services were homeless in the past 6 months compared to 34% of the usual care group. Vouchers, it turned out, cost less than shelters in this population. Vouchers cost on average $1,172 a month. Rapid rehousing cost $880 a month. Transitional housing cost $2,700 a month. And emergency shelters, or the usual care group, spent about $4,800 a month in shelter services, but still 1/3 of them remained homeless. Rapid rehousing connects families and individuals to permanent housing via a tailored package of assistance. This can serve as a bridge to longer-term support like rental vouchers. It is time-limited rental assistance coupled with targeted supportive services like housing identification, rent and move-in assistance, and case management and services. It's best used in a progressive engagement model where some people really only need the short-term boost to regain their housing. Others might really need a longer-term voucher. Studies have shown 75 to 91% of households remain housed a year later, but I can tell you in the family option study that over time, this really worked best if it was a bridge to vouchers. It is not probably a substitute for vouchers, but can be a very reasonable bridge because you might be able to have some families who don't ever need vouchers and while you're waiting for vouchers to become available. So what is the role of shelter in homelessness? Shelters are an extremely important part of the emergency crisis response, but they do not equal housing. They need to be part of the process to get people housed. And shelters, when they're effective, are low barrier. They allow people to bring their pets, their partners, and their possessions in and to have privacy. We know shelters are working effectively when their length of stay is short and they don't have returns to unsheltered homelessness or stays in homelessness. COVID has made clear, however, the risk of congregate shelters. We have seen time and time again severe outbreaks in congregate shelters in homeless populations across the country. To summarize interventions, we know prevention works, especially and only if it's targeted to the highest risk individuals. Once homeless, we need to offer housing first. Some people need services. Those people need permanent supportive housing with voluntary services. Other people, like families, often just need housing, and you can save the money on the services by just getting them housing. Some people can benefit from short-term interventions like rapid rehousing to divert them from homelessness or to shorten an episode of homelessness. We face many challenges in doing this. There is an enormous shortage of deeply affordable housing, and it is difficult to create housing for ELI renters without significant subsidies. To prevent and end homelessness, we desperately need to identify ways to stop the inflow into homelessness, and this may become even more important in the COVID pandemic. However, we have seen that it can be challenging to target resources to those at highest risk. The COVID pandemic presents new and difficult challenges, and we are anticipating increases in homelessness just at a time when state and local resources are limited and the risks of homelessness are higher than ever. Some final thoughts. Homelessness in this country is reaching crisis proportion. The primary causes are structural, not individual. I want to remind you that we actually know how to care for people with mental health and substance use problems. We just find it very difficult to do so when they're homeless. Stagnant wages for low-income workers, a shortage of ELI housing, and structural racism create the underlying structural conditions that fuel homelessness. We need to protect, preserve, and produce ELI housing, and we need to focus prevention resources on the highest risk populations. We need to use housing first principles for everyone else. And as I always like to remind everyone, as a physician, I have to say that there is simply no medicine as powerful as housing. We know how to end homelessness. All we lack is the will. And I hope through this talk, I've convinced you to join me as an evangelist for preventing and ending homelessness. It doesn't have to be this way, and I hope you will join me in working to build a world where homelessness is rare and short. With that, I will leave you with my contact information, and I'm happy to take questions.
Thank you, Margot. I think for those who want to ask a question, the process here is you would hover over the participant box on the bottom of your Zoom, select the ... more button, and there's a raise hand option. And Stephanie is going to help moderate some questions for Margot. You'll be placed in the order that you raise your hand. So while folks are kind of getting that, I want to ask one question. I'll take the privilege here of asking one question, Margot, because I think this is, it's great you're from California. I know California in general has a a really tough unsheltered population problem. And that's obviously the most visible thing from a political perspective in any community, and it certainly is here in Utah. So, you know, how, if I were to say, you know, people that only see the unsheltered side of this and don't really understand the intervention side, how do you kind of work with that political reality and helping to, you know, explain what it is you're trying to do to address those populations?
Yeah, I think it's a great question, and I think it's a big challenge because people, you know, when you spend time in, you know, with unsheltered populations, what is often most traumatic are the people with significant behavioral health disabilities. You're much less likely to notice the person living quietly in their car who's going off to work at Walmart every day. And you're likely to really see and recognize the individual with very visible mental health or substance use challenges. And people really don't believe that those individuals can be housed. I think we need to do a lot better job of reminding people of the evidence, although my friend and colleague who runs the, Mark Horvath, who runs the Invisible People site, reminds me that people don't really respond to evidence. What they respond to are stories. And we probably need to do a lot better job telling the stories of the fact that even people with those really significant behavioral health disabilities can be successfully housed. We see it every day. And those of us in the field know that how you are at the worst sort of moment in your life isn't how you are forever. I think, you know, we need to do a better job getting the word out there that this is possible, that with outreach workers, with compassionate care, and with the availability of housing, we actually know how to end homelessness, even for the most highly visible, highly suffering populations. You know, our study in Santa Clara, I think, really helped turn the Santa Clara County's thinking around, because many people, it was really common for mayors or city council people or others to say, oh, it's not like you can take someone with severe addiction and just stick them in housing. And what I like to say is not only can we, but we must, because it's, as a physician, I can tell you, it's extraordinarily hard to treat those conditions when someone's living outside in a tent, and it all gets so much easier once we get to housing. I think we need to change the narrative and take the narrative back from a discussion of individual blame. You know, we see time and time again that people blame homelessness on substance use or mental health, and I like to remind people, as a physician, you'd be shocked how many people have substance use and mental health problems. It's extraordinarily common. And I like to say to audiences, you know, most likely, if you're honest with yourself, if you look within your own family or your own close social network, and I will include myself in this, you have a loved one who struggles with a severe mental health or substance use problem. And I like to say, if you don't, you're either not paying enough attention, or you should go out and buy a lottery ticket because you're so unusually lucky. And I think what we know for those of us, and again, I'll include me in this, I have very close family members with very significant mental health and substance use challenges, and they're housed. They get mental health care when they need it. That care is compassionate. It's targeted to their needs. We work with them through their substance abuse challenges with using evidence-based practices without stigma, without judgment, treating it as the complex medical problem that it is, that's often a response to complex trauma. And guess what? They're housed. These conditions don't have to be equivalent to homelessness. And I think we really need to change the conversation away from that. And I think the best thing we can do is help, you know, recruit. I feel like my job is sort of recruit evangelists to this cause, to go home and talk to your friends and family about it, and to explain with sort of a compassion and evidence and calmness. I know it looks scary. I know it's really upsetting. I know it damages business communities and all of that. This is in all of our benefit to fix, and it's entirely fixable.
Great. Stephanie, do we have a question, I think, from?
We do. We have a question from an attendee with the last name of Egerton Goff. Please feel free to ask your question.
Good morning. I'm curious if you can share with us the funding sources for the studies. We see in Salt Lake City and in Utah a lot of emphasis on government spending towards homelessness, and I'm curious if there are private entities participating.
Yeah, that's a great question. So for instance, the Santa Clara project was very interesting. The funding mechanism, the government was, A, didn't have a ton of money, and B, was very nervous about using their money for what they thought when we started this project 7 years ago was very edgy. You know, they were like, how are we gonna say to the public, we're gonna spend public funds to house people with lots of jail stays and lots of drug use and all the rest. So they got funding through this mechanism called Pay for Success, which is a mechanism where the government recruits private funders. And so it was a combination of philanthropists and banks, frankly, making an investment in this program. And the way it works is that those entities put up the money to fund the housing. And then external evaluators, of which I was one of them, are called in to determine whether the program works with sort of metrics that we all agree on ahead of time. If the program works, the government agrees to pay for it, and the private funders receive their money back with some interest, depending on whether they were a foundation or a bank. The banks got higher interest. I think the foundations just got their money back without interest. And if the program doesn't work, then the investors or the foundations and the banks pay for it. And this is viewed as a way for governments to take risks, because the government sort of said, well, if it works according to our preordained criteria, then we'd be happy to pay for it. But if all these folks are just going to wind up homeless anyway, we don't want to be left holding the bag. And so it reduced their risk. And the investors thought, well, this is a way they could do well by doing good. Because, for instance, the banks, because it was successful, actually got the money back with interest. So it was sort of a win-win. That is one common funding model that is starting as a way to try to get proof of concept for things, or for governments that are reluctant to do things. I will tell you that the scale of the costs to actually end the homelessness crisis are so high that, to be honest, I don't think we're going to do it without getting the federal government involved. But just to give you a scale issue, we could choose to fully fund the voucher program so that everybody who qualifies gets it for on the order of about $31 to $35 billion a year. And that sounds like a lot of money, but for the federal government, that is a rounding error. Like, they don't even, that is a tiny amount of money for the federal government. They could flip a switch and fund every person in the country who qualifies for vouchers tonight. Now, if they did that, you might argue, well, we need more housing stock, so that people could get it, and they would probably need to support that too. That is an enormous amount of money for a local government to provide vouchers for every person who needs it. For the federal government, it's basically a rounding error. And so I think that the short term, I think these public-private partnerships are a great way to move the ball forward. I think for the long term, we're going to need to get the federal government involved.
Great. I don't see any other hands up, so maybe I'll ask one more question before you go, Margot. You talk a lot about the housing first. We're big believers in housing first here in Utah. I think
Yes.
it's what we believe in. I think some of our challenge is, you mentioned, we should be trying to identify populations that need less assistance and really make a quick housing intervention, and obviously folks that need more intensive interventions. We have that as well, but what is it that we can do inside of our emergency shelters to identify those populations? Oftentimes it's not super apparent, and
Yes.
are there some best practices on how we can really focus on moving those folks out with the limited intervention with just housing assistance, as opposed to those who really need that intensive care?
That's a really great question. And I will say that the evidence base is sort of early in building for that. Generally, what we're seeing is, because resources are so limited, that when we use our coordinated entry system, in most places, they're only really prioritizing those with the highest needs, and they're waiting for like permanent supportive housing beds. And there are many low needs people where there's just no resources left. Some programs like Los Angeles, who raised a lot of money through Measure H and Measure HH, moved to what they're calling housing problem solving, where they have very, very, very flexible funds. Funds that can be used for anything from, hey, you just need your first and last month's rent, to, hey, you know, you're on SSI and we can get you an apartment for this. And if you had an extra $200 a month, that would be enough. To, hey, you know, oh, your sister said she'll take you in, but the whole reason she's not taking you in is she doesn't have a bunk bed, and so there's no place for your kid to speak. They gave the agency complete flexibility to sort of do whatever they needed to do. Like literally they could go to IKEA and buy a bunk bed, or they could pay off, you know, some bad debt, or they could pay the first and last month's rent, or they could give a shallow subsidy. And that seems promising. So what they're doing is in a coordinated entry process for people who score lower. They're just sort of asking people and just have sort of good old-fashioned social work of like, what is it going to take to get you housed? And what they're discovering is that a lot of people kind of know what it would take, and often it's just not that much. I think, you know, the data is still out on, you know, how durable those responses will be, but I'm a big fan of things like shallow subsidies. We've got a lot of people on, let's say, SSDI, or maybe while they're homeless, they can get their application in for SSDI. And then you can look and you can say, hey, realistically, they could pay even 40% of their household income, which is a lot, but on rent. And the difference between the, you know, the rental apartment that I'm getting for them and their 40% is $150 a month. That is like a day and a half in a shelter. Let's just give them $150 a month shallow subsidy while we work it out. I think you're going to start seeing more interventions like that. The best programs that I've seen are using this model of progressive engagement. They're sort of getting everyone, you know, up to speed. They're doing a lot of intensive benefits counseling. They're doing job training, getting people back in the market, and they're doing housing navigation. Because for many of these folks, it's difficult for them to go to landlords. So you see these agencies going and sort of talking to landlords and trying to come up with a win-win. Look, I'll guarantee the rent if they're bad for it. I'll put down the security deposit. I'll negotiate with the landlord. And then they're basically taking a whatever it takes. And I think the key there is flexibility, because what we found is for some people it's a one-time payment, some people it's a shallow ongoing subsidy, some people it's a bunk bed, and some people it's things we could never even think of. And that seems to be a really best practice that I think we're going to see more of.
Yeah, I think we have 3 questions in the queue. I think that's what we have time, about 5 minutes. So maybe some quick Q&A here on those 3 questions. Stephanie, can you help moderate that for us?
Absolutely. Our first question comes from Margarita. Please feel free to ask your question. Oh. Looks like she's muted.
Margarita, could you unmute yourself?
Oh, okay, can you hear me now? I'm so sorry.
Perfect.
I thought I hit that button.
No worries. Perfect.
And I hope that the question I'm asking is that I'm asking it in the right place. But my coalition has been given some funding to work with, you know, our community to deal with COVID. I've been helping several families and individuals who are now homeless because they've lost their job due to COVID. And many of them, some of the individuals I work with, seem to be stuck in this homeless crisis. They're in and out, but they always go to these specific motels. Yep. And I was talking to the guy at the front of the desk, and he told me that, yes, he deals with a lot of homeless families that come to the motel. The cost per night is like $60, you know, and it's really hard for them to stay in. And I thought, man, this would be a great opportunity for like the housing association to work with these types of places as a kind of an halfway house from, you know, being kicked out of their home, going into a hotel, and then from a hotel into a more permanent solution. Have you guys thought of something like that? Or I know you've seen this. I don't know. My heart goes out to them.
Yeah, that's a great question. I mean, you know, over the long run, you know, of course, we don't want families in motels because it's not perfect. But as you say, it's safe. It's better than a congregate shelter. So I'll say a few things. With the COVID crisis in California, we got FEMA money to actually move people into hotels. And because our tourism industry completely collapsed with COVID, that it was like a win-win. The hotels were glad to be full. We got people out of shelters and off the streets who were high risk. And so that was called Project Roomkey. FEMA did a 75% match. The counties and the state put up the rest of the money. And now the governor has pushed through a program where we have something called Home Key, where we're actually buying a lot of those hotels, permanently and turning them into housing, sort of throwing in kitchens and things like that. I think that there is a possibility to think about using things like ESG or emergency service grants that came through with the CARES Act to do things like get motel stays. Obviously, with families, we want to get them into permanent housing. And when you think $60 a day, by the end of the month, you probably could rent an apartment for that month, if you know that much, if you could get the money up front. But there is probably a way to think of that as an emergency response, like a shelter, that would be a lot safer during COVID.
Okay, next question.
Next question is from Margaret Hofstetter.
Margaret, if you could unmute yourself.
Okay.
Go ahead, Margaret.
I'm so sorry. I do not have a question. I have been navigating the system and just...
No worries.
That is okay. We will move on to our last question is from username Kitenge. Please unmute yourself.
Am I still open?
Okay, Kitenge, go ahead.
Yes. Yeah, my question going to I'm sorry, I said your name wrong, is Margot?
Margot.
Mm-hmm. Yeah.
So my question is, I understand your explanation about the percentage of homelessness, especially in Salt Lake City. With your expertise, what is the primary cause of homelessness? Is the lack of affordable housing, or the income household have serious housing problem due to the higher cost of the housing? Because the condition of what you spend, if you could just tell me a little bit about your experiences of homelessness.
Yeah,
because
that's a great
question. That I think about that.
It's really the mismatch between what households can afford and what housing costs. And you can fix it by doing one of two things. You can either increase household income or you can decrease the cost of housing. Now, obviously, if we just increased everyone's household income and didn't do anything about increasing the housing stock, it's possible that housing prices would just go up. But what we really need to do is close that mismatch, because wages have been stagnant and housing costs have gone way up, and we just haven't produced enough low income housing. You know, what we see is that in communities where there's less of a mismatch between the cost of living and the cost of housing, there's lower homelessness. And in communities like mine in San Francisco, where there's enormously high housing costs and a really great amount of income inequality, we see extraordinary high rates of homelessness. So I think that the solution is sort of a both and an and. We need to produce more ELI housing because we just don't even have the housing stock. We need to lower the cost of that housing, which mostly is going to be done through things like subsidies. And then we need, whether it's individual or, you know, to the community, so that their rental housing costs are lower. And then we need to make sure that people's income keeps up with that. We need to really focus on things on like rising the pay for these low wage jobs, which we've seen through the COVID pandemic. We call them essential work for a very important reason. They are essential. None of us could survive without them, but we certainly don't pay them as if they were essential. You know, in the Bay Area, we have been fighting for years for 15 to increase the minimum wage to $15. Our housing wage in the Bay Area is $60 an hour. Only households where the income earner makes $60 an hour, if you have 3 people in the household, could they actually afford to live there? So you can see the huge mismatch, like what happens when we're fighting really hard just to get it to 15. We're not there yet. And yet what we really need is 60. And what I often say to businesses in the community is, look, you guys need to do your job. You need to pay, you need to pay your low wage workers well. Pay your janitors, pay your cafeteria workers. But I also say to them, let's be real, you're not going to pay those folks $60 an hour. So I need you on the front lines of, using your political power, talking to the legislators, talking to your federal representatives to get more housing subsidies, because that's kind of our choice. We're either going to have more homelessness, we're going to raise the minimum wage way up, or we're going to decrease the cost of housing. We can't continue to blame people who are homeless for their predicament when our structural conditions are so bad. And so that is the conversations that I've had, is you both need, for these business owners, need to be good community members and pay their low wage workers well, but they also need to recognize it is in their interest to advocate for more housing affordability, which we're really going to need state and federal subsidies to do.
Great, thank you, Margot. I normally would have a thunderous applause for all your hard work in presenting and answering questions and helping educate us, but thank you so much for joining us. We hope to be in touch with you in the future and be evangelists on the front lines with you as well. So thank you very much for joining us.
Thank you so much for having me, and it's wonderful to meet you all. Okay, be well. Bye-bye.
So our next group of presenters are going to speak to us through pre-recorded messages. We have a message from Evelyn Lim, who's the regional administrator for HUD, and she has a message about HUD's pandemic response. And then in lieu of our traditional award ceremony, we wanted to recognize all of the hard work and accomplishments during this unprecedented year with the local homeless coordinating committee. So we have folks from our Utah Homeless Network and our beloved Pamela Atkinson to highlight those successes. So we're going to go to that video real quick, and I hope you enjoy.
Hi, I'm Evelyn Lim, HUD's Rocky Mountain Regional Administrator. I'm honored to offer some thoughts for Utah's annual Homeless Summit this year. The fact that this is a virtual conference today is a sign of the times, and I'm so glad to be part of the discussion on such important topics that affect the well-being of families in our communities. I want to commend everyone here today for all the work you've done to help people throughout Utah find homes during this very, very challenging time in our nation's history. I worked for President George W. Bush's White House and actually worked on pandemic planning in 2006 and 2007. During that time, I learned the importance of planning, communication, and flexibility to change course at any moment for efficient crisis response. When Secretary Carson was added to the White House Coronavirus Task Force in March, I was asked to help support his role there, as well as lead HUD's response to pandemic. Through the CARES Act, HUD received $12.4 billion in supplemental funding for our largest programs. $9 billion for community planning and development, $2.2 billion for public and Indian housing, and $1 billion for our housing office. We worked quickly to allocate funds to our partners and grantees, knowing that additional funding was urgently needed. HUD awarded $21 million in ESG funds and over $124,000 in HOPWA funds to Utah under the CARES Act legislation. That funding can be used for shelters, homeless outreach, and prevention during this unprecedented time. These CARES Act funds are designed to help contain the spread of coronavirus among homeless individuals and also provide state, local, and tribal governments with homelessness prevention funding for individuals and families who would otherwise become homeless due to coronavirus. As Secretary Carson and President Trump have said, no one should lose their homes due to this virus. We are encouraging our grantees to utilize funds for rental assistance and other ways to help people stay in their homes. Several communities in Utah are using HUD funds to provide rental and mortgage assistance, as well as utility assistance. And those of us at HUD are working to streamline, expedite, and in some cases, waive red tape to get the funds working in our communities for the people we serve right away. Local coordination can be difficult even in normal times, and the fact that the work of your organization endures is a testament to your dedication and innovation in this difficult time. I want to commend all of you for the tireless work you do to ensure our most vulnerable in our communities get the support and housing they need. In times like these, I continue to find examples of how together we innovate, create, and coordinate throughout this pandemic. That's no more truer than in Utah. Thank you again for the opportunity to speak to you today. But mostly, thank you for all the work you do. I hope to see you all soon in person. In the meantime, take care and thank you for your partnership and your continued work in the community.